Good morning. Today is Wednesday, April 15th. I am Allison Johnston, Professional Development Coordinator for the Maryland's Department of Health's Developmental Disabilities Administration. We welcome you to today's webinar, which is the CMRO Provider Meeting. If you would like to use closed captioning, you can read what is being said by clicking this button. Sometimes the transcription is not exact, but it is close. All attendees are currently in listen-only mode. You are muted and your mics and camera are turned off. Today's presentation is available in the handout section. Click here where you see the paperclip to download the presentation. If you have a question you would like us to read and answer, please click here where you see the question mark to add your question, and we will get to that during today's presentation. Now at this time, I would like to introduce Bianca Renwick, Director of CMRO. Good morning, Bianca.
Good morning, everyone, and welcome to our April quarterly provider meeting. We are going to have a lot of information today. We have several guests to us, presenters this morning, as we have a lot of new information and updates we would like to share with you. So this morning, you will be hearing from MPrime, a CQL update. You're going to get some statewide updates, and then we will go along and provide our regional specific information. So I would like to just invite our guests from the Medicaid office to provide an update. Again, most folks are in listen-only mode. If there's a question, please drop it in the chat. There will be some additional follow-up of questions for later if we're able to, but if you have a question for the presenter, just put it in the chat. We will be monitoring the chat. We may not get to every question today. Again, this is a very packed meeting, so go ahead and take notes where you can, and we will do our best to get to everything that we can today. So I'm going to go ahead and again welcome you to our April quarterly meeting, and the Medicaid team, if you're ready to queue up the information for MPrime, Charlie and team.
Hi, good morning, everyone. This is Charlie Crisp. I'm the director for the Office of Medicaid Provider Services. I'm joined by my assistant director, Lucas Rodriguez, who oversees provider policy compliance and communications, and also by Jennifer Marsek, who is the assistant director for Medicaid provider enrollment. Today, we are here to present to you on the upcoming transition from our current enrollment system, ePrep, to our new enrollment system, MPrime, that will take place later this fall. Lucas, I'm going to hand it over to you to walk through the presentation.
Thanks, Charlie. Good morning, everyone. As Charlie said, my name is Lucas Rodriguez, and I'm the Acting Assistant Director over our Policy and Communications and Compliance divisions. Really quickly, before we jump into the heart of this presentation, I just want to kind of set some expectations about what you're going to hear today. As Charlie said, we are transitioning to our new MPrime enrollment system. This is intended to be kind of an initial overview presentation as we review with this group what the transition to MPrime is, what the major milestones look like, and what providers can expect from that process. This is not intended to be a completely comprehensive and exhaustive overview of the system or a training on how to use the system or anything like that. That will all come in due time. But we just wanted to kind of work to get the initial word out, and hopefully we'll be invited back to a future meeting to provide additional information as we're making it available. With that, if we want to go to our next slide. One more. Great. So MPrime is the new enrollment system that will be replacing our current enrollment system, ePrep. It is currently scheduled to go live in October of 2026, and MPrime stands for the Maryland Provider Registration and Information Management Enterprise. MPrime is intended to be a secure web-based platform that will allow users to independently access information, manage their accounts, and resolve issues 24/7 without the need to directly contact support staff. What this essentially means is we worked really hard to ensure that the MPrime system is a provider-facing and self-directed system. We want to make sure that providers are able to get the information when they need it in a way that's intuitive and meaningful to them as they access the system. So we're really hopeful that providers will be able to find a lot of the information organically as they're accessing the system. But don't worry, if you still do need any assistance or help as you're navigating the MPrime system, in particular during the transition, we will still have our email and call center based support avenues available if necessary. Next slide, please. So our current system, ePrep, is a vendor contracted system. What that essentially means is we work with a third-party vendor outside of the state who supports that system and works with the state to ensure that the ePrep system is responsive to state needs. We are very excited, however, to announce that MPrime is a state-built, owned, and operated system. The team has been working on this for many, many years, and we're very excited that we've been able to build this from the ground up. What that essentially means is that we've been able to take a lot of the lessons learned, both positive and negative from our experiences with ePrep and the provider experiences with ePrep to ensure that the MPrime system is responsive to those different feedback and lessons learned during that process. In addition, we really are viewing MPrime as kind of the first step or a foundation for a larger provider ecosystem or provider portal that will encompass the different aspects that Maryland Medicaid providers need to interact with the state in regards to. So while MPrime is very much just focused and exclusively focused on the provider enrollment aspect, we really are seeing this as kind of an initial foundation to build a much larger provider portal and interconnected kind of provider ecosystem that will contain all of the providers' requirements as they navigate their Maryland Medicaid obligations. So we're hoping that in the kind of years to come, we'll be able to provide additional information as to how we're expanding this MPrime process to include additional information. But we're hopeful to be able to provide that information in the near future. If we go to the next slide. The intent of this presentation is to really go over some of the major milestones that providers will be experiencing as they navigate their transition to MPrime. So as we can see on this timeline, the go live for MPrime is in October of 2026, but we do have a couple of different steps that we have to hit before we get there. The main change that a lot of providers will be seeing in the coming months is that we are instituting a application hold for all of our moderate and high risk providers starting July 1st, which DDA providers, to my understanding, are moderate risk providers. So that will be when your application hold goes into effect. You do also see here that we are sending out early revalidation notices. However, DDA providers do revalidate on a single continuous cycle, so that shouldn't really impact this group. And so I won't go into it in much detail. And then in addition, we'll kind of talk through the different training expectations and what providers can expect from that process later in the fall. So if we go to the next slide. So as I mentioned earlier, we're not expecting that any of the DDA providers will be impacted by the early revalidation notices. But if there's any questions regarding the revalidation process, you're definitely welcome to reach out to us at our delegated inbox that is included at the end of this presentation. So we'll actually skip this slide and go to the next one. So the main thing that we want all of our providers to keep in mind as we transition to MPrime, one of the very important things for us here at the state is ensuring that all of the data that is currently loaded in our different systems is successfully migrated to MPrime and available for providers on day one of the system. We want to ensure that all of that information is present, accessible, and complete. In order to ensure that that happens, what we do need to do is ensure that all of the applications that have been submitted to ePrep and are currently in process are reviewed and entered into our system in advance of that date. In order to make this happen, what we are doing is we are implementing an application hold starting July 1st for all moderate and high risk providers. What that essentially means is that starting on July 1st, you will be unable to submit any additional applications into the ePrep system. Any applications that are submitted prior to July 1st will still be worked and processed in accordance with all of the existing policies and procedures. but any new applications or updates to your existing provider enrollment applications will be unable to be made after July 1st. So we are asking providers where possible to ensure that they're submitting any changes that they need to make to their enrollment status, completing any new enrollments that they might be expecting to have to make in advance of that July 1st deadline, so that all of those applications are in our system and we can work them before we transition to MPRIME later in the fall. If we go to the next slide, and then for our limited risk provider types, which doesn't apply to this group, they will have their application holds go into effect August 1st. And then if we go to the next slide, the next thing that we know is really on top of the forefront of providers' minds is training with the system. We've already gotten a lot of questions about from providers as to when they can see the system, when they'll be able to get access to it, when they'll be able to understand what's expected of them as part of this transition. So rest assured, we are working on ensuring all of that information is available. Currently, we're scheduling and building out a training schedule that will be going into effect in August and September of 2026. We want to ensure that we're providing these trainings much closer to the time that that information will be needed to be used by providers in the October go live date. So those trainings will be happening in the fall, much closer to that go live date. A couple of things that you can expect from those trainings. You can expect a better understanding of how to navigate the new portal. You can expect to better understand the system functions with a particular emphasis on the new features that are available as part of MPRIME that might not have been available in ePrep. You should also get a good understanding of the intricacies associated with your applications and how to navigate any addenda or additional requirements as part of your application process. And then also any reporting features that may be available to your provider type. In addition, we will be working to ensure that these trainings are tailored and kind of specific to different provider groups and their needs. So for example, we understand that this audience, a DDA provider, will have different needs and uses of the system than someone like, for example, a large hospital chain who might have different things that they need to use in the MPRIME system. So we'll be working to ensure that the trainings that you're receiving are tailored to your specific needs and are kind of considering what features and functions are most important to you in the system. We will be sharing additional information regarding these registration details closer to the start date, so keep an eye out for those as we approach the summer and early fall. Next slide, please. So the last thing I wanted to go over are just additional resources. So we have issued 2 transmittals on this subject. PT 5926 was the first transmittal, and it just informed our providers of our intent to transition from ePrep to a new enrollment system and provided information regarding the application holds. There was a second transmittal that was then sent, 6526, which provided additional guidance regarding some of the frequently asked questions that we had been receiving and provided a delegated inbox where providers were able to ask questions. So all of those frequently asked questions and resources that we have available, many of which we already covered today, are available on the MPRIME webpage, which is linked to there. We do ask that if you have any questions, if you have any specific use cases that you want to discuss with the state, please review those FAQs before reaching out to us. That information will be kept accurate and up to date as we navigate this process. And so it's really important to us here at the state that providers are reviewing that information before they reach out and ask questions to ensure that that guidance hasn't already been provided. In addition, if you do have a specific question regarding MPRIME or need guidance on a specific scenario that you do not believe is covered in the FAQs, you can reach out to us at that mdh.mprimegolive@maryland.gov email address. We do ask that any questions that are related to the MPRIME Go Live, please be directed to that delegated inbox. We understand that you may have other contacts at the state, other staff members that you work with, or other delegated inboxes that you reach out to, but we're really asking all of our providers to direct all of their MPRIME questions to that inbox. That will ensure that somebody who is familiar with the content and working closely on the MPRIME transition is able to address those questions and get you the most accurate and up-to-date information possible. With that, I do understand that we have a packed agenda today. That concludes our presentation. So if there's any immediate questions, we're happy to take those now, but in the sake of time, if we need to move on, we're also welcome to take questions to that delegated inbox. Thank you.
not sure that I'm seeing any questions related to E-Prime. Several people indicated that okay, so they're asking, is the go live date October 1st or later in October?
So right now we're scheduled to transition from ePrep to M-Prime the weekend of October 9th. So Friday, October 9th, we will cease operations with ePrep. We'll do cutover that long weekend, which is Columbus Day weekend, and our first day or M-Prime will go live on Tuesday, October 13th.
Okay. Do we have a process for providers that may have an emergency between July and October?
Yes. So as we get closer to implementing those application hold dates, additional information will be shared regarding providers who may have an urgent or an emergent need and need to enroll a new site during that application hold process. But we're asking providers to honor those application holds and do their best to get applications in ahead of time.
Got it. Thank you.
Mhm.
So they said that a number of providers have reported that they did not receive the transmittals. If this is going to be the method of communicating, please review to ensure all providers can receive. So I'm going to add something to this, Charlie, and then you can add for it.
Go ahead.
There are several ways for provider agencies to get information from the department. And so we'll try to get that to you guys because a lot of people are reporting that just across even our DDA communication. So we don't confirm you get it, right? We send the link. There's a link out that folks have to put themselves on a mailing list. And we are asking for providers to continue to review that information because as assigned folks have left an agency, another person may not have been included. So specifically for DDA notices, we'll take a look at that as well. And so Charlie, I'm not sure if you guys are sending your stuff up on, okay, and you said the updates are on the M Prime webpage, is that correct?
Correct. So the two transmittals that Lucas referenced in the presentation are available on that M-Prime Go Live website. Medicaid is also hearing from providers that similarly, there's just been staff turnover and the individuals who did receive transmittals previously have left. So then the entity or the provider is not receiving the communications. So Medicaid is also making sure that we're sending out communications to every email address that we have on file in efforts to cast kind of a wide net to ensure that the communications are being disseminated and reaching the appropriate parties. So similar to DDA, Medicaid is also taking additional steps to ensure all communications are going out to all providers, whether they're directly impacting them or not, just making sure that the information is getting out there and being shared.
Provider indicated they did not get the transmittal regarding M Prime. I believe a communication was sent out. I will confirm that date and see if we can get it sent back out again to the DDA community. So we have a repeat question that you've already answered about July, and the handout did not have M Prime information. It does, right? So the attachment is the list is on there, and the presentation was the handout for M Prime. So Sean, we're gonna take a look at that again, if and not just email. So again, the MDH has a listserv, and it tells you the sites, the departments, that you're able to click on if you want a transmission, and that includes DDA as well. And DDA we have a portal where we ask for providers to join in on our listserv. So again, hearing that some of this information needs to be sent out, we'll try to get it out to you guys. If we're not able to attach the information to the meeting today, we'll see if we can get it sent out in another specifically to the CMRO teams, CMRO providers. Okay, I am not seeing any other questions regarding this. So Charlie, I think you guys are good. Thank you. And thank you for spending time with us. And for those of you who are who operate in different waivers, in different regions, this information will be provided again at the rest of the meeting. So if someone else on your team needs to hear it, they can join on to the Western, and I think Central are the two. Southern haven't done yet, so that information will be shared there as well. So we're going to give our CQL updates. And so welcome, team. Go ahead.
Thank you very much. All right, next, got it. Okay, I am Rebecca Casey. I am the Director of Personal Outcome Measures here with the Council on Quality and Leadership, and I'm presenting today with Elizabeth. Elizabeth, I'll let you introduce yourself.
Thank you, Rebecca. I am Elizabeth Seitz, the Director of Organizational Excellence for CQL. Welcome.
All right, so we get to talk today about your progress and the provider impact toward network accreditation. So we are with the Council on Quality and Leadership, CQL, and we have been working closely with Liberty Healthcare Corporation as well as with DDA since about mid-2022 to really help Maryland move forward with providing information, data, looking at all of the areas where there's opportunities for improvement and there's pockets of excellence. And we have enough data now that we can present that to all of you. So next slide, please. I know many of you are aware of who CQL is, so just a really quick overview for those who may not be as aware. Our vision is a world of dignity, opportunity, and community for all people. CQL has been a thought leader within the disability field since the late 60s and has really been focused on this as a way to really improve services for people with disabilities as well as people with mental health conditions. Our mission, which is very similar to the mission that you probably have at your organizations, and that we share and align with DDA and with Liberty, is that we're dedicated to the definition, measurement, and improvement of personal quality of life. So today we're going to talk through some of that. Next slide, please. So we are going to talk through the journey to network accreditation really quickly. Then we're going to have Elizabeth go through the basic assurances review data to tell you how the review of different providers has shown some areas of strength in their systems and practice, as well as some areas of opportunity. I will go over the personal outcome measures data to do the same and talk about those areas of strength and opportunity when it comes to the outcome and support. And then Elizabeth will talk about some of the differences between the data, and we'll come back to me to talk about where we're going. Next slide, please. So to talk about the journey toward network accreditation, we have really been focused on providing a lot of support over the years to DDA and Liberty. So we really started at a capacity building phase of training all of the Liberty staff and the DDA staff around what are the basic assurances and what are the personal outcome measures and how can we have you implement these. We then moved into a lot more focus on the infrastructure that DDA and Maryland may need to help support these changes. So CQL has been working with DDA and Liberty on policy reviews. We've worked with stakeholders, and we really have been spending a lot of time looking at the data to help view how we can provide recommendations. So we finally have enough data. We're going to make some recommendations and on improvement and move forward. So I'm going to have you skip the next slide because I think the image is not there, and then go to the next one, and I'll hand it over to Elizabeth.
Thank you, Rebecca. We're going to start by discussing the basic assurances review data and how it can be used to improve services and supports. During network accreditation, Liberty Healthcare staff reviews the systems and practices in all of these areas. As you can see, there are 9 of the 10 factors of the basic assurances listed here. And this includes rights, protection, and promotion, and dignity and respect, to facilitating and supporting development of relationships, best possible health, and so forth and so on. So again, these are basic assurances factors that are looked at during a basic assurances review. Within each of these 9 factor areas are what we call indicators or subtopics. And then each indicator is reviewed at what we call in system and in practice. So for each of those areas, system includes looking at trainings or policies, surveys, processes. And when we talk about systems, we're looking for robust, reliable, and sustainable systems to be present. Each indicator also, we look at practice, and practice is measured through observation, evidence that the system is being followed. And we also do that, or it's also done through focus groups and conversations amongst people at the organization. Next slide. So in the basic assurances reviews done by Liberty, these were actually started in April of 2023. And so the data that you are looking at is based on 119 basic assurances reviews across the state. There aren't national comparisons for basic assurances like there are for personal outcome measures, because it really isn't an apples to apples situation. There are lots of variables depending on if an organization is already accredited by CQL versus not accredited, the size of an organization, the types of services provided, and so on. When we bring up an indicator or factor area as far as the data, we're going to talk about what each of these mean, and then we'll talk about some things that can be done to really enhance or to increase the areas where there were opportunities. So in the most present areas in system, so this means that systems are established within organizations. As you can see from the data, 2 of the top 5 areas were within the area of safety. So physical environments, promoting health, safety, and independence, and routine inspections of environments are sanitary and hazard free. So this means that, 95% and then 83% of organizations have strong systems in place in those areas. 2 other areas are around the area of health. And those systems are around people receiving their medications safely and effectively, and staff are able to immediately recognize and respond to medical emergencies. So organizations have good systems in place in both of those areas. As far as practice, again, we see similarities. The highest areas where the practice is present, again, are in the same areas of safety. So the physical environment, promoting health, safety, and independence, and routine inspections. So not only is there systems in place in these areas, but these things are actually happening consistently across an organization in practice. Again, you can see 2 of the top areas in practice that are present are in the area of health as well. The same 2 areas where the system is present. Again, staff immediately recognizing, responding to medical emergencies at 91%, and people receiving medications and treatments safely and effectively at roughly the same, around 90%. The only difference in practice was that the area around business, administrative, and other functions promote personal outcomes, meaning that around 91.5% of organizations had practices in place for those support functions within an organization to support the direct service part of the provider. Okay, next slide. Now, as far as indicator areas that were found to be least present in system, 3 of the 5 areas were around rights protection and promotion. And so areas of opportunity as far as systems go included supporting people to exercise their rights and responsibilities, which only 1.67% of providers during these basic assurances reviews had a system in place to do this. Also, decision-making supports being provided, and then staff recognizing and honoring people's rights. So there's definitely an area of opportunity amongst providers when it comes to robust and reliable systems in place in the area of rights protection and promotion. Additionally, in the areas of system where policies and practices around the area of relationships, and then providing individualized safety supports. So unlike the areas of safety that were found to be most often present, the area of safety in need of opportunity is around the individualized component of safety supports. Now, in practice, again, the area of rights definitely was an area of opportunity that was seen during VA reviews, as well as, like we saw in system, providing individualized safety supports. But what we also saw, or what was also seen in practice as some areas of opportunity, were around people having supports to manage their own health care. So people really having choice and control and active involvement in their healthcare, as well as indicator 8A, which is around the planning process. So people's plans leading to truly person-centered and person-directed services and supports. Next slide. So suggestions for improving rights protection and promotion. As we saw, these were definitely areas of opportunities. So things to think about are educating people that you support, staff and family members around really what constitutes a right or having a right, and then promoting the exercise of rights and protecting rights. And when CQL talks about rights protection and promotion, it's not just about service rights, but about human, legal, and civil rights afforded to everyone in this country. And when we talk about robust, reliable, and sustainable, we mean it's not just done on a one-time basis, handing someone a piece of paper that talks about their rights. It's about discovering what rights are most important to people, what they understand about their rights, and what support they want and need. And then once you have that information, it's easier to develop and implement more individualized ongoing education in this area. And then secondly, we want to understand and educate all stakeholders about alternative decision-making supports and the limits of guardianship. When we talk about all stakeholders, we're talking about the people that are being supported. We're talking about staff. We're talking about organizational leaders, family members. But we want to make sure there's a really good understanding about what those alternatives are that exist and what the limits of guardianship really are, so people can really be supported in decision making. Next slide. The next area is about best possible health. As we saw, there was some areas of opportunity there. And so ways to improve systems and practices in this area are number one, to start by finding out how people define their own best possible health. And not just physical health, but mental health and their spiritual health and wellness. And then finding individualized ways to help people manage their own healthcare and wellness activities. And this could be from choosing doctors to making appointments, monitoring blood pressure, learning about medications, and tracking daily step counts. It's really about any and all involvement and management of wellness. That's what's important. It can be big, it can be little, but it's about active participation, not being a passive recipient in healthcare. And then, of course, presume competence and ensure that the person making healthcare decisions is provided with all the information to make those decisions, just like any of us would be. It's very few people make healthcare decisions in a vacuum. Many of us often go to other people for advice and support. We might go to Google to look up information, and we would expect that people with disabilities are getting that same support as well. Next slide. For safe environments, again, there were some very strong areas for providers when it came to safety, but there was one area that really there was some opportunity for improvement. So Ways to improve the system in practice is really about discovering and providing only necessary individualized safety supports, starting from the person's perspective, asking them what helps them feel safe. What is something that makes them anxious or nervous or scared? So considering safety and understanding safety from the perspective of the person receiving services, not just from a clinical or organizational or family perspective, but knowing what safety really means to them. Also, consider the use of technology and how it might provide more independence and a sense of safety and security for people. And then we want to ensure that safety supports really balance dignity of risk and duty of care. And then, of course, we want to make sure with all this information that there's regular review and updates to protocols and supports with the person's input. Last is around the area of positive services and supports, and how can we improve systems and practices in that area. So next slide. Really, it starts with making sure that people are realizing goals that matter to them, ensuring people are directing their teams and plans and their meetings, and helping people create understandable, meaningful versions of their person-centered plans. And these might be a mood board or a flipboard on a tablet, a board game or picture book. There's lots of different ways that people can get creative and to just extract the most important information out of the official plan, if you will, and being able to show to others what's most important to them in a way that's meaningful to them. And of course, ensuring that any assessment or discovery tools that are being used focus on strengths. Of course, you're going to look at, risks and you're going to look at other things, but it should always start from the perspective of what the person can do rather than what they can do or can't do or what their limitations are. So next slide. Now I'm going to turn it over to Rebecca to talk about and share some personal outcome measures data.
Great. Thank you, Elizabeth. All right, next slide, please. So we're going to talk about the personal outcome measure data that's being used for services and supports. So you see the list here. I do want to just note that Liberty Healthcare, along with DDA, and a lot of you on this call have really worked to complete a ton of personal outcome measure interviews with people receiving services and someone who knows them best. So there's been nearly 800 completed since the beginning of this in July of 2022. So that's really impressive. Want to give a big shout out because I know that takes a lot of work to coordinate both on the provider side and with Liberty. So with these areas, just like how Elizabeth was talking about factors and indicators and discussing those areas, personal outcome measures uses a similar language. We have the factor areas of those big factors you see of human security, community, relationships, choices, and goals. But then we have these indicator areas, and these are when we go down more to the nitty gritty about what we expect people to have for quality of life. So it's safety, it's being free from abuse, it's health, it's being treated fairly, it's participating in your community, being able to be connected to the relationships you want and the way that you want, making choices about your life, and also being able to have goals. We look at these in two different areas as well. So like basic assurances where they do system and practice, we do outcome and support. So the outcome is looking at what the person wants for their life. The supports are whether or not those services and supports are matching that. So when we're talking through here, you'll see outcomes and you'll see supports. Just remember the outcome means it's personally defined by the person. And then supports are how you as providers are providing supports and services to help that person have quality of services. Next slide, please. So let's talk about the 5 indicators most present. So what we see for these indicators are the outcomes and supports are really similar to what we see with the national data. So people are safe nationally is actually the top outcome and support too. So Maryland is showing a really similar pattern for the way that their data is showing for the most present support. So you can see over half of people who were interviewed with disabilities are safe in their outcomes. So they feel safe. They live, work, and pursue leisure in safe environments. On the support side, almost around 60% of people have the supports to be safe. You can see that the next one is realize goals, and that means that people achieve goals in in the last 1 to 2 years they've achieved something they're proud of. You can also see nearly half of people have that outcome present, so they are achieving something and noticing it. And then about 34% of supports are, about 1 in 3 people are receiving the support to celebrate when they achieve goals, to recognize that achievement. You can see use environments on both. About 46% of people are using their environments at home, at work, or in the community. Where on the support side, about 37% of organizations are providing that support to people. They have that support in place. Integration is about you being able to spend time in places with people with and without disabilities, just like any of us. So this is integrated in the greater community, and you're not just going to a day program, going to a group home, going into really, really specific community activities in a small group. It's more integrated than that. So about 36% of people have that. You can also see that they have interact with the community at 35%. So people are talking to people, ordering their food, providing money, discussing things with people, talking to members. On the support side, one area that wasn't or 2 areas that weren't discussed were continuity and security. So do I have the change I want in my life? Am I able to control the amount of change where it can be controlled? Do I have full control over that? And so on the support side, people are not receiving the supports to be able to do that financially, about future planning as often, but it's still at 40%. So still one of the more present supports. And then respected, around 30% of people have the supports to be respected because organizations are focusing on how we can be most respectful to people. Next slide, please. So let's talk about the least present indicators when it comes to personal outcome measure data. You'll also see that they are similar between outcomes and supports here. What I will also tell you is nationally, choose services is one of the lowest areas. So when we see this in the least present area, this also shows and reflects what we see nationally, which is people are not choosing the services they have. Those services might be their services that they get through Medicaid, but it's also the generic and generally available community resources. Am I grocery shopping where I want to? Am I going to the doctor I want to go to? And am I going to the Medicaid provider that I'd like to? So only about 11% of people are choosing services. About 15% of people have social roles. So you can also see in supports that this is reflected too. So about 15% of people have that outcome, but only about 8% of people have the support. And what that shows is that those social roles, those meaningful, beneficial, and really reciprocal relationships where we would be missed if we did not show up, those relationships that we have, whether it's a volunteer opportunity or maybe you're just a really good neighbor and you grab somebody's mail every day, that people do not have those as present as they would like, and supports are not supporting that area as much. You can see choose where and with whom to live are in both of these as well. Only about 16% of people are choosing where they live and who they live with, and only 14% of organizations are providing the supports to be able to truly inform people about those options. So what we see throughout that is that there are really big opportunities to really explore and think about that. And we're going to talk through some ideas as well. Decide when to share personal information. Only about 18% of people are deciding when to share their personal information. And that means that they may not know all the information that's on file about them. And then you can see exercise rights between both of these as well. About 19% of people have that outcome present, whereas 15% have the supports in place. So what that means is that people need a lot more support to exercise their rights, have the education to do that, but also to really help hone down what rights are most important and is somebody exercising those. So on that bottom row of supports, intimate relationships was another area that we didn't touch on because it isn't an outcome area. But those are not only romantic relationships, those are those close relationships we form with anyone. So really thinking about how to do that. Next slide, please. So let's talk through some ideas about what suggestions we have. The first one is about choosing services. So if we're looking at how to choose services, we would really recommend that providers look at ways to discover people's preferences, whether on how they're spending their earned and benefit income, and doing this through informed choice of educating those experience people have and to be exposed to that. When you do that, you might do that through a preferences assessment. You may do that through conversations. You might do that through a discovery process or a survey, some other way to discover those preferences. The next area is just working with people on their preferences and current situation to really create plans with their preferences in mind. So after you learn about those preferences, we should support people with a plan. Creating a plan of how they may want to access other services may take time. Think about how financial limitations might take time for yourself to plan where you want to go and access services. Maybe there's a restaurant you really want to try that you never tried, or an area of town you haven't been in or explored as much because of income, but it doesn't mean you never get to, right? We still get to plan. Find and connect to generally available services. We know providers provide a lot of services. That doesn't mean that you provide all of them. A lot of communities have a ton of services. So looking at how that helps people. Do they need to go to the food bank? Is this an area where they go to a local community center? Maybe they're an older person and they would love to go to the senior citizen center. What are the areas that we're looking to choose those services more and not just look within our field? And then providing support and opportunities for people to make truly informed choice. We're going to talk about informed choice. You've heard it before, but that's really important. Next slide. Choosing where and with whom to live. The beginning is always discovering the person's preferences for their living arrangement. Again, assessments, surveys, conversations, ways that we can understand that. Is it a one bedroom that you may want to live in? Is that financially feasible for you? Maybe you want to live with 2 other people only. Maybe living with 6 people would be impossible, because for most of us, it probably would. And then I grew up in a big family, so I know a lot of us probably feel that. Use personal choices and characteristics to guide how you assist people. So once we know those, how do we guide people to different housing, right? It's not just what's available within our provider network, it's what's available to everyone, right? And everyone within that income, everyone who is able to afford that. But what are those? And then we may need to advocate across the community to enhance and expand options for all people. We know affordable housing is hard to find. So we might also have to advocate at our community level to ask for better options for people so that we can truly have that other aspect, which is we are advocates. All right, next slide, please. So people exercise their rights. So, one thing that Elizabeth talked about, and she gave great ideas, is thinking about those preference assessments, thinking about how we look at what's important to people for rights, surveys, all of those areas. How are we going to assist the person once we realize that to fully exercise their rights and choices? If the right to freely associate with others is a huge right for them, how do we make that happen, right? So how is it that you are improving their communication options, maybe giving them a phone, really providing that option for people to have a plan? And then we have to provide training and support people to help recognize and understand personal freedoms. We know a lot of people, including the staff that we have working do not know all the rights that are afforded to everyone and don't necessarily know how to support those. If it is one that maybe they themselves don't care about exercising as much, but the person they support does. So how do we start moving toward that? Is providing training, providing education, providing good options to people so they really truly understand it. Next slide, please. And then social roles. So those meaningful roles that we have that really bring meaning to us, those can be in a variety of ways. You could be a club member, or it could just be one of your personal roles that you have in your life, but you would be missed if you were not showing up with it. So we want people to have that informed choice, that education, experience, and exposure. We want to find out what's most important when it comes to feeling like you have a sense of belonging and that there's reciprocity. And then we want to support people to expand their current roles by learning new things, because just like you or I, we have different social roles today than we used to. Maybe you learned to knit during the pandemic and now you're part of a knitting circle. So we want to make sure that we support people to expand those. All right, next slide, please. I'm going to pass it back to Elizabeth for a little bit.
Okay. Thank you, Rebecca. Really great information. Now we're going to discuss some of the similarities and some of the difference between what was learned with the POM data and with the basic assurances data. Next slide. So for both rights and safety, what was found was similar in the data. So for rights, people and organizations need more information, education, and support. Within this area as well, this should include, again, identification of rights, promotion, and protection. And make sure that all rights are reviewed with the person, not just service rights. So these were some things that were found in both personal outcome measures data and the basic assurances data. Lots of rights are maybe reviewed once a year again, but those really mainly just focus on service rights and not the rights of a human being, a citizen, a person living within the United States. For safety, there were similarities in that it's an overall area of strength in both the POM and the BA data. And it's most likely due to regulations around safety. As we know, in pretty much every state in the country, as well as other countries, safety is highly regulated. And so it's not surprising that a couple areas of safety had the highest kind of data, if you will. So that's an area of strength, and it could be related to the massive regulations around safety. And then, of course, for organizations, they also had a lot of safety systems in place, assessments and inspections, maintenance. Those are things that are going well and are strong in most providers. The goal now is to take all that information and ensure that they are individualized, like we talked about in the basic assurances, for the person. So understanding what's important to each person from their perspective when it comes to safety. Next slide. One of the main differences that the data shows is in the area of health. Now, for basic assurances data, there are strong systems and practices with things such as training, record-keeping systems, and ensuring that staff respond to both acute and emergent health concerns. Now, the POM data, though, shows that outcomes and supports are near 30% only. So there's an area of opportunity. The POM is focused on the person's involvement in managing and understanding their own health and healthcare. And that actually aligns with indicator 5A of the basic assurances, which was seen as an opportunity and was within those areas, the 5 least present areas, because that is the area where it talks about people having supports to manage their own health care. So these are just some of the similarities and the difference between what was learned with basic assurances data and with the POM data. And I'll pass it back over to Rebecca to kind of finish this off and talk about next steps and where we're going. Next slide.
Thank you. Thank you, Elizabeth. So we talked about how we did capacity building earlier. We talked about how we also helped with infrastructure, including policies. The next steps are really going to be around meeting with a variety of stakeholders, providers, people receiving services, representatives from the state, representatives from Liberty, both virtually and in person, to be able to get as much feedback as possible to help support you in your transformation toward network accreditation. So that is really what we're going to focus on. We'll continue having Liberty collect POM and BA data. It's very valuable information. We're going to skip the next slide. And then I'm just going to ask, what questions do you have for us? And I'll have you guys go ahead and pull the last slide, our contact information up in case anybody would like to contact us directly. So does anybody have any questions?
No, there are no current questions I can see at this time. So thank you for your presentation.
And thank you. And I thank you to all of Maryland for your commitment to this network accreditation and transformation. We appreciate it.
Thank you.
Next slide, please, Allison. We are on to our statewide updates. We have Ms. Nicole Shepard, who will provide some information and updates to you guys. That is statewide. Nicole?
Good morning, and thank you, Bianca. I am Nicole Shepard, and I am the Assistant Director of Provider Services, and I am here just to provide you guys with an update on the Developmental Disabilities Administration's Employment Data Initiative. Next slide. So the Maryland Developmental Disabilities Administration partners with the University of Massachusetts, the Institute of Community Inclusion, and the State Employment Leadership Network to collect and analyze data on employment outcomes through the Maryland Employment Outcome Information System. So the system was created to track participants' employment goals across the system. It helps us identify ways to increase performance and collects long-term data to support Maryland's effort to increase participation in integrated employment and improve the quality of employment outcomes. And this is as Maryland is an employment first state. Next slide. So all meaningful day and employment service provider organizations are required to collect and submit data twice annually in May and October for 2 consecutive weeks by the established deadline. Executive directors may designate a designee for these responsibilities and must notify the DDA of any changes to the executive directors and or designees' contact information so that communication can be updated promptly.
Nicole, I'm sorry. Can I interrupt you very
Yes.
quickly?
Yes.
The guests are saying they're unable to hear you clearly. So can you either speak louder or get closer to your mic? They're having a
Sure
hard
can.
time hearing you.
Okay.
Thank you.
Okay, thank you. So all meaningful day and employment service provider organizations are required to collect and submit the data twice annually in May and October for 2 consecutive weeks by the established deadline. The executive directors may designate a designee for these responsibilities, and you must notify DDA of any changes to the executive directors and or the designee's contact information so that the communications can be updated promptly. Next slide. So the next reporting period will occur in May of 2026. So all of the meaningful day and employment providers on May 1st, you will receive an email from John Shepard with the University of Massachusetts Boston Institute for Community Inclusion. This email will identify the specific 2-week data collection period, and all required data for the May reporting cycle must be entered no later than July 17th. So just to reiterate, you will receive an email on May 1st that lets you know which 2 weeks in May that you will have to collect the data. And then that information must be reported no later than July 17th of 2026. If anyone needs more information, please review the March 23rd, 2026 webinar, Overview of DDA's Employment and Meaningful Day Outcomes Information System, which is on our YouTube page. That is actually all that I have. And if anyone has any questions, please let me know, or you can email me as well.
Okay, let me check to see if we have any questions. It says previously they were able to pick a 2-week period. They are asking if now this option, the only option available to them is a predetermined date.
Yes, it is going to be a predetermined date that Mr. John Shepherd will send to you on May 1st.
Okay, and then the second question indicates that the data collection for community engagement is very different in the new cycle. Do we know yet how the changes were decided, and can we have more time? So let me get the first part.
Okay.
We would not necessarily share how they were decided, but if Nicole does not have the information on and I'm not sure whether or not the time is negotiable. Nicole?
The time is not negotiable. It has to be in that 2-week time period that John is going to send out.
That's what I assumed. And if you guys have any specific information or any support that you might need from us, please direct those questions to the regional office provider services team, and we will work to provide some technical assistance as well as to gather any additional questions or concerns you may have. I am not seeing any other questions. And Cindy, I'm seeing your concern. We will circle back to you offline. Okay, not seeing any questions. So we're going to go ahead with some CMRO updates right now. Next slide, please. And our order of the CMRO updates have changed a bit. So we do, I think we have provider services up. Allison, the slide hasn't changed for me yet. There we go. So we talked about a lot of what you heard prior is very provider intense. And so we wanted to ensure that we provided provider services updates. Next, we are receiving a lot of plans where we're finding out that parents and other relatives are in the home with the person receiving services. We just wanted to make you aware that supported living, the waiver requirements indicates that that person cannot live with a family member or it cannot be at their family home. As we come across some of those that we might have missed on the plan review, we are asking for plans to be updated to change the service model, because it is not the service model for individuals to be living with their family members or relatives in the home. So be aware of that. We've kicked back about 4 of those in the last 40 days or so. The person receiving supported living is required to be listed on the lease as the lessee and not just as the tenant. We do know that providers are often supporting individuals as guarantors because or family members also are guarantors when the leasing person requires someone that they are certain they need that person, and we're okay with that. So Sean, yeah, to your question, yes, it's okay, but the person has to be on the lease and they cannot be living with family members. So, but please make sure that this is being done, and the turnaround time to fix those are not going to be very long when we find them. So we're asking for you guys to do a QA check on your supported living sites to ensure that those services are being implemented in alignment with the current DDA waiver. We're literally, if we get it on a Monday, we're giving people until the Friday to update it, because the alternative is requesting payment back, and we're trying not to do that. If the individual wants to, the people can live with whomever they want. It just cannot be a family member. If the person wants to live with their significant other, and you guys are okay with providing the services, that will be your individual agency policy and practice, and so that will be up to you. If the agency does a corporate lease, they should be listed as the occupant if you have a corporate lease with an agency. The issue, and that would be either personal supports, or or residential services. So the person has to be a co-lessee. They cannot just be an occupant. Please review the waiver information, not the policy, the waiver. It's outlined in there. Okay. Our team also wants to ask that you address your billing issues to the provider services liaison, and then we will review and determine how best to triage your concerns. Please do not send billing issues to the plan review teams or to the QE teams. We also ask that you also look at the PCPs to ensure that the information in the plan is what you sent in and that you accepted, or what you have accepted has changed. We are getting a lot of requests to fix plans after submission because someone missed something, or they did not review it. Mistakes happen. We don't want to penalize, but for me, the big concern is we're getting those questions about billing months down the road instead of within a 30-day window. Just a reminder, on transition to LTSS, we ask for providers to bill monthly. Please alert the regional office staff as soon as you know there's an issue. It will allow us to be able to quicker resolve your concern than trying to figure out what happened 4 months ago. Next slide, please. Hold on 1 second. What if the home is given to the provider in the will? If the home is given to the provider, then the person does not own the home, and they would have to sign a lease. So that would be a different designation, because that home would not belong to the person. If the person is receiving housing support, no. So if they're receiving housing support, they can live in their home, but the service is not supported living. That will have to be personal supports. They cannot be in a home with family members. Okay. 2 siblings receiving services, that's fine. And again, the idea is that they cannot be living with parents, family members, sister, brother, someone who is within the home with them. Again, please refer to the waiver language. That will assist in you understanding what compliance looks like for that service. Next slide, please. Try to encourage y'all to go back to the waiver. Okay, these MA numbers. Please ensure that you're sending your MA number approval letters. Oh, go back one more, sorry. To the provider services team so that we can turn on your sites. That's another issue we're having with billing because the sites are not turned on. Allison, can you go back one slide, please? Okay. As well as overnight supports. So please let us know that you guys are getting kickbacks and pushbacks, billing issues because the homes have not been configured appropriately. If we do not have this information, we cannot set up the sites in order to do that. Please also understand that your rate may change based on the timing of a PCP. If all PCPs are approved, then you will see the 3-person rate. If we still have a plan that is not compliant, not approved, it's not there, or yes, that person, you will see an impact on your rate. The rate can change daily depending on the occupancy. But most importantly, please ensure that every site you need to have turned on. Please provide the number of residents, the configuration, if overnight needs to happen. So for every site that needs to be turned on, please ensure that that information is shared with the provider services team. And of course, please remember to utilize the provider portal manual first when issues arise. It should be able to tell you what is the reason for the concerns, and you may be able to problem solve. And I am going to add one more update. Please, when you are emailing us, I know you guys send a lot of screenshots. I can't pull an LTSS ID number from a screenshot. Please put the LTSS ID numbers in the body of the email or in the info so we can actually copy it and go into the system to see what you're doing. It's I promise you that that is the difference between me sending you another email and getting back to you in 2 days than looking it right away when we're getting it done and can provide some faster feedback. So please let us know that when you guys have an issue, please include the LTSS ID number. And when you are sending issues regarding billing, please add the CCSs as well. We're getting several emails about the same billing concern to several teams in order to do that. No, it does not go to a general CMRO email. It goes to your your provider services liaison. If you are unsure who your provider services person is, you can send that information to Travis and Patrick, and they will triage it as appropriate. Next slide, please. Okay, I'm just gonna talk because we're kind of tight for time. CMRO is growing. We have currently 254 approved providers in the Central Maryland region. From July, we have reviewed 282 new provider applications, 53 individual nursing support provider applications were reviewed and approved, 7 individual behavioral support provider applications were reviewed and approved. If you guys are asking about those, these are our providers that work specifically with our SDS folks, and information was sent out to them so that they needed to submit some applications to us. We also reviewed 222 agency provider applications. We were only able to approve 11. Our team has performed 105 community setting rule site visits, and 61 new provider site visits were conducted. So please understand, when you send an email, you may not be able it may take a day or two for the team to get back to you because they're probably in the field. So again, just asking that you are patient with our team and give us 24 to 48 hours on a return. If you have an emergency, I am always available for any emergent situations. But if it's not emergent, please give the team about a 48-hour timeline in order to get back to you. Next slide, please. Oh, you guys just got the update regarding ePrep and MPrime. We just wanted again to remind you that the information you got is valid, and we've heard the limitations and the timelines. So please do our best to adhere to those. And again, as Charlie indicated, if you have any emergencies, we would see how we may be able to assist. But where you can plan ahead, we are asking you to please do so in order to ensure that your sites can be ready and you are able to assist and bill. In that vein, folks, if we're going to receive an influx of ePrep applications and new site inspections. This will impact the provider services team's ability to respond to your email inquiries. So please be guided accordingly. They're going to take a little bit more time to get back to you if they're doing site visits. Okay. Next slide, please. Okay, eligibility waiver. Billing. This is a big one. And so we are getting a lot of concerns about, again, billing, haven't been paid, can't accept services. A lot of these issues are related to waiver and or eligibility issues. So please, we are encouraging teams to track the medical assistance and redetermination efforts. If these processes are not kept up to date and someone falls out of the waiver, we are unable to compensate if we do not have an active waiver. We are asking that redeterminations not be mailed to the regional office. We are asking that redeterminations be sent to the coordinator to be uploaded into LTSS. I encountered this week where providers were uploading REDETs into LTSS, but it is not in the place that the waiver unit is looking for it. So please, the process is laid out. It's very clear. If you need for us to send you the concurrent waiver process, it is actually on DDA's website as a training tool. It is necessary to please include the coordinators. You may not be the rep payee, and as such, any letters regarding redeterminations may not come directly to you. Please check in with your family members who are the representative payees and ask them weekly, monthly, whether or not they've received any information regarding redetermination. We cannot track it if we cannot see it in the system. If we're able to see it in the system, DDA staff can advocate on your behalf. But when we get a, hey, it's been mailed and it's somewhere, we don't know where it is. So please follow the process, include the CCSs. If you're having any challenges with getting the CCS to respond, please pull us into the conversation so we can provide some guidance and support. Most importantly, this is also TY season. Do not start services without a waiver approval. We will talk about that a little bit later. Next slide, please. Okay. PCP reviews, plan reviews, gentle reminders. Please submit the PCPs at about 20 days out. We're getting some PCPs that are 3-4 months out. I know, Bianca, you guys don't always get to them on time. There's a reason for that. We're getting an influx of plans that are being submitted way too early, and it is impacting the region's ability to get to the plans that are due because we're getting them based on we're tapping them based on when they're submitted as well as when it's due. Clarifications are to be returned to the regional office in 5 business days. Please adhere to this where you can, because we are running out of options to be able to extend some of those dates. We do not want plans to go into auto extend. We're working internally to address that on our end, and we need your support. Please ensure that if someone requires an HRST review, that is done. If they require that their behavior plans and any nursing care plans are current and up to date so that we're able to review this information and not have to send it back for those what we consider administrative concerns. We are asking a lot of things that we would like to share with you. Please ensure that we have schedules. We're asking for schedules for meaningful day employment personal supports so that we're able to understand where services are utilizing so we can match the amount of hours for the right service and that we ensure that there is no overlap. Again, I just mentioned behavior plans and nursing care plans. When we are asking for schedules specifically for personal supports, and community supports. We are looking at the task schedule. Please be gently reminded, personal supports should not constitute only ADLs. They have to have integration and learning. People need to be out in the communities if they're getting personal supports, and CDS is 100% community. Okay, we're getting requests for 40 hours of CDS, and the plan says John will be in the community for 3 days. That is not 40 hours of CDS. Please be guided accordingly. Behavior plans with rights restrictions must be agreed to and signed by the standing committee. Behavior plans without right restrictions should be agreed to and signed by the individual and or legal guardian and or authorized representative. If the plans are not signed, they are not complete. If it is a draft, it is not complete. In order to make a determination regarding services that need a behavior plan, those behavior plans have to be current. Please work with the CCS and really the CCS is not the person that should be checking with the BSS provider, right? So the team needs to work together to ensure that the BSS provider has what they need in order to get the plan submitted on time, especially when we have to renew services. And they do not necessarily line up with the plan. So if it's April and the behavior plan should have been updated in February, and in April we're getting a plan with February of 2025, we're not going to be able to move that plan. So please be guided accordingly. Please, where possible, explore and utilize other community resources and state plan services, such as Community First Choice and DOORS, prior to requesting DDA services. We still remain the payer of last resort. Next slide, please. Okay, again, CMRO has been busy. The department, our office has approved 7,925 PCPs since January 2025. We are reviewing the majority of our plans within 14 days, right? So we got about 3,000 plans within 7 days, 4,900 plans within 20 days, and 1,800 plans beyond 20 days. Again, we're also working internally on our 20-day numbers, and so we appreciate your support, understanding, flexibility, and all of that in order to get us to get there. Next slide, please. Fiscal, please remember to reconcile your payments to ensure all of your sites are receiving proper payments. If you have any concerns regarding any payment concerns, please reach out to George Opren at the regional office. So he might be able to provide any support and guidance that you may need. If you do not remember the name, you guys can shoot us an email again and we'll send it. But George has been around for a while, so I'm going to assume that most people know how to get a hold of George. Next slide, please. Okay, Marty's going to present all of the information with our nursing updates.
Good morning, everybody. This is Marty. So just as a reminder about the minimum required trainings for nurses to be working in the DDA setting, there is the initial RN case management delegating nurse training. This is now available monthly. After the nurse finishes the RN CMDN course, they are then required to take the HRST rater. Once they finish that, the advanced rater, and then once they finish that, the clinical reviewer training. All three of the HRST trainings are available on the HRST. The agency would have to submit to HRST CCing the regional nurse for the region the nurse is in for authorization to have access to the HRST once that RN case management delegating nurse course is finished. Next slide. Next slide. Again, the HRST training, it is online. It cannot be completed until after the initial RNCMDN training has been completed. For the provider to submit the RN, the provider must first have a gatekeeper identified. That gatekeeper is set up with Adrian Holloman. Once that gatekeeper is set up, then the gatekeeper would submit the spreadsheet that Adrian will give with the RN information. And then for Central Region, when you're submitting for nurses to have access, you would CC Kelly Jones on the email you're sending to mdsupport@replacingrisk.com so that Kelly can verify that the nurse has completed the required training. Next slide.
Next slide, Allison. It's stuck on our end.
There we go. So HRST requirements, the HRST has to be rated within 90 days of the PCP and as condition changes. If the condition changes, the expectation really is that the HRST is updated within 14 days of those changes. The rating is completed primarily by the CCS, so the RN CMDN can complete the rating. If that HRST score is 3 or above, the RN CMDN must complete a clinical review of the HRST within 14 days of the rating. Please be aware, there is no nursing support service simply for the review of the HRST, the clinical review of the HRST. Anybody who has an HRST score of 3 or above requires nursing support services to do an assessment of the individual, to do the self-med assessment, and to do the HRST clinical review. The nurse will determine which nursing support service is appropriate for that person based on those assessments, either nurse consultation, nurse health case management, or nurse delegation. Consultation and health case management occur no more than every 90 days and minimally annually. Nurse delegation occurs minimally every 45 days and is based on the delegation of medication administration, and the people giving medications have to be CMTs. Next slide. For nursing care plans, the nursing care plan is a blueprint for the direct support staff to follow to provide care that is under the nurse. It is basically a brief description of what the issue is for the person and then what the staff is supposed to do. Whether they're monitoring or doing a skill, it should be specific and describe what specifically the staff is doing, how often they're doing it, where they are in relation to the person if that's indicated, and what to do when they see something that's not how they're supposed to, what they're supposed to see. So when do they call the nurse or when do they call 911? It's very specific to healthcare and to the health related skills that are under the delegation of the nurse for that provision of care. Next slide. Okay, for Central Regions, this is just some data to be aware of. Our number one hospital admission for fiscal year 26 Q2, the top 3 actually were urinary tract infections, falls, and seizures, pneumonia coming in 4th, and sepsis, which is that severe infection that can kill because it shuts down the organs, is the 5th leading cause of incidence. Next slide. For total incidents, not simply just hospitalizations, but of health-related or somatic issues, fall actually is our number one. Falls are our number one reported health issue. Please be aware with falls to think about the person's movement, when they're moving, how they're moving, what to do to be aware that they're moving. Please make sure that you're considering things like chair alarms and bed alarms to alert people of when movement is occurring, getting physical therapy and occupational therapy involved for strengthening and for learning how to use any kind of supportive equipment, and to do environmental assessments to identify risks that may be present in the environment of care to reduce those risks. Seizures was our second leading cause, urinary tract infection, third leading cause of hospitalizations. Next slide, or sorry, of incidents. Next slide. For deaths, this our number one cause of death this quarter was cardiac arrest, or this past quarter is cardiac arrest, which kind of mimics what is occurring in the general population, as cardiac issues are the number one cause of death for folks in general. As you'll note, seizure comes in at second with 4. The red indicates it's a secondary cause, secondary diagnosis, not a primary diagnosis. So something else was happening that would have been the primary cause, with seizure coming in as a secondary. Our respiratory issues continue to be present, and up there we have 4 related to aspiration. If you look further down the line, you'll also see respiratory failure from pulmonary embolism, respiratory failure from aspiration pneumonia, and respiratory failure, number 4 cause, just as a respiratory failure. So respiratory issues do affect our folks inordinately. Please make sure that people are trained in any choking or dysphagia training. As you'll note, we had 2 deaths related to choking last quarter. We do have, where it is available online, the choking and dysphagia train the trainer training. For folks, I think that became available about 6 months ago, so please take advantage of that. Please also be aware the HRST has free training. The DDA is funding this free training on the Fatal 5. The Fatal 5 includes aspiration choking, it includes bowel dehydration, sepsis, seizure, and GERD. Next. So for the Fatal 5+1, again, we talked about, I just spoke about that we have available training for free for all DSPs and all nurses through the HRST. I believe that the Fatal 5 is implicated in 42% of the deaths that we had last quarter for Central Region. The Fatal 5 are aspiration, bowel obstruction, choking, dehydration, seizure, and sepsis. We also have an additional that we get, and I believe that's the dehydration for training. So we're getting 6 trainings for 5. Next slide. Okay, so 51% of the incidents reviewed and 44% of the deaths were related to the Fatal 5 for our region. Please be aware, we need to intervene early. One of those early interventions, or one of those requirements, according to 1022 for individual specific training, would be those trainings that meet the needs of the individual. Prevention is the key here, so please make sure that staff are trained in any health issues that the person has, and that take advantage of that free training the DDA is actually paying for. That is available, again, to all DSPs and all RNs within the HRST. Next slide. It's quality enhancement now. Thank you.
Thank you. Hello, Shireen. You're right.
Yes, I'm here. Good morning, everyone. Thank you for this opportunity to share just a brief moment about some things that we see within the quality enhancement team And before I say anything else, I want to thank all providers for all that they do, for all of the hard work that they do behind the scenes and upfront, especially as it relates to incident reporting. So what you see on the screen today covers January 1st through February 28th of this year. And I ran a data poll on 10% of all incident reports in the categories of abuse, death, and neglect. And I wanted to find out if the providers were taking the first initial steps upon notifying DDA of any type of incident in these specific categories. Was the provider taking the initial steps to ensure the health and safety of the actual individual affected by the incident and any other individuals that could be affected by the incident? And lo and behold, the answer is truly yes. So what you see is I took 72 incidents of abuse, 28 deaths, and 79 instances of neglect. And in all of these 179 reports, the providers took the initial steps to ensure the health and safety of the person affected and those who had the potential of being affected. So that is cause to give yourself applause. So I want to say thank you to everyone for doing what you do. It is extremely difficult when you're in the midst of an incident to ensure A, the person that's involved is safe, and then B, all others who could potentially be injured or sustain some harm. So thank you so much for giving me a moment of reprieve to say, yes, the providers are actually doing what they're supposed to do. Now, we do have situations where things don't look as rosy as they are, and we are here to help you navigate through those difficult situations. Next slide, please. Just a couple of reminders. We are asking, well, this has been in place since September of 2024. All quality assurance renewal plans need to be sent to the email address listed on the slide, QEteam.CMRO@maryland.gov. This is a specific email inbox designated for QE plans. Please, 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 if you send it to me directly, I may miss it, but if you send it to that email and to me, it will not be missed. If a QA plan is submitted to anybody else outside of this specific email address, again, there's no guarantee that you're going to get a response or you're going to get an approval letter. This is not on the slide, but I want to share this. If you are a new provider and you have not started serving individuals, and it is time for you to submit a renewal plan, you don't submit a plan, you submit a letter requesting to have your existing plan continue for the next upcoming year. If you have any questions whatsoever, that's when you can send me an email and I will give you the language that you need to put in the email to request an extension. There is a document, a Google Doc, that will be attached for you to reference anytime that you are doing your QA plan. Some of the basic fundamental things that are required to be in your annual report. And this is what the staff looks at when they are doing your review. If it does not have these specific things, you know automatically it's going to come back requesting revision. So if you utilize this Google Doc that's attached and your plan contains all of these specific things, you're more than likely going to get an approval. Again, I thank you all for all that you do. Thank you for being supportive throughout DDA's transitional process. And I look forward to continuing being of service. Thank you for the opportunity to share.
Thank you, Shireen. I have realized we have several questions. So, oh, that's the slide I was looking for. This is just before I do the questions. These are all of the key details regarding the transition for the M Prime. So this slide is here on number 73 for those, if you can download it, that gives you the timelines. Okay. I forgot to move. I didn't move it up when I updated the slide. So let's look at some questions. So the free Fatal 5 training request, DDA has continued to send this out on all of our communications, but Marty will tell us where it's located.
So to have your folks, to have your DSPs to be able to take advantage of that free Fatal 5 training, the gatekeeper submits the information for the DSPs, their name, their email address, etc., directly to HRST at that MD support at replacingrisk.com. So the same process that you use to send your nurse in, you use to send your DSPs, minus you do not have to CC the regional nurse when you are sending to have DSPs have access to the HRST.
Okay. And if you guys have any concerns, y'all can flag those to the regional office nurses, Marty and Kelly, and they would be able to do that. What is the effective date of forwarding a QA plan / report? That has been in place. If you have emailed Shireen for any reason, at the bottom of her signature actually tells you about the email address to send it in order for us to for her to get this. So Shireen, can you just respond to
Yes, that has been in place.
Yeah.
It's been in place since September of 2024. If you ever sent me an email regarding anything outside of the QA plan, at the bottom where my signature is in red letters, it tells you where you should send your QA plan renewals or questions or requests, etc. So if you can take that email down now, and if you have a question, send it to that email address and you will certainly get a response.
Okay, thank you. Hold on, we got a couple more. Is there an alternative way to obtain redetermination dates? Every provider here is a Medicaid provider. Medicaid has a system called the EVS, the Electronic Verification System, that providers can sign up for. It does come with a fee, but that is one. That is another mechanism that can be utilized to check it. We do not. This is again the dates. That's an EDD function. The CCSs do check monthly and definitely before every quarterly meeting, because so that they can provide updates to the team regarding the letters. Individuals most times will also get a letter to their representative payee. Please ensure that addresses are updated with Medicaid. Now with DDA, we know what your addresses are. Your address for us is where we pay you, where the person's living. If you have not updated the address with Medicaid, with the DHS, with all of Social Security, MMIS, the feds don't have the waiver unit doesn't have that new address. So you have to ensure that that the addresses are updated everywhere within the system. Okay. Hold on. Someone said they really enjoyed the training, so thank you. Okay, Kimberly, I need to look into that and I'll get back to you directly. So shoot me an email. Putting a law with a key on the outside of the bedroom door, that is not just a right, that is actually not a rights restriction. That is community settings rule requirement. Now, a lock on the outside of a door, right? So if the key's on the outside, then that we would anticipate the person should be able to unlock their door from the inside and would have a key to access their room. If you put a locked door, the lock on the outside, and the person is not able to get out of their room until somebody gets them out, that is actually shouldn't happen. So yeah, if that's in the plan, we're going to kick it back. That should never happen at all. But that is very much a rights restriction. Who else? I think what so we assist with EDD follow-ups where we can. Please understand DDA will not necessarily have a response to give because this is not our system. We also may not have the answer to your EDD related concern quickly again because we are not in control of that information. It is really us just making sure that we are flagging to EDD when you guys let us know there's a concern. Sometimes we are able to review the information and provide some guidance that we can and we will. But if it's something that the waiver unit has to fix, we do not have any authority or timeline to tell you what that fix is. We just are able to let them know that we have a situation that we need some support with. Lauren, I probably need to follow back up with you to address some of those so I can understand what my team is missing and we can provide some questions. For waiver renewal, no, ma'am, that's not what I said. The letters for the waiver renewals tells you that it should be also uploaded to MD Think. So we also ask that the CCSs be provided a copy in order to upload it into LTSS. So you can do all three. Some providers are still, the letters also give you an address where you can mail it, but DDA can only see when it is done in order to support you when there may be a delay in getting a response for the waiver. Please follow the directions on the redetermination letters. The extra step is to give it to the CCS so that they can upload it in the renewal section of the of LTSS so we can provide support as needed. Also submit the waivers, the redets timely. Some redets are not done until we get the final letter that this stuff is getting ready to close down. So there's that. No, not every behavior plan goes through a human rights restriction. The guidance on that remains the same. We've not provided any other guidance about every behavior plan going through the Human Rights Committee. As a practice, if you want to review that, that will be up to you, but that is not a requirement. The guidelines as to which plans have to go through a Human Rights Committee remains unchanged. If you don't have any pending ePrep applications, there's nothing that you have to do. Yeah, okay, let's go to my updates because we're running out of time. Next slide, please. These are important things that we need to do that. Renewal applications for provider renewal goes to the provider application email. That has been the practice and the request. We are not asked, we are, where you can, do not send documents to someone's personal email. If someone is off, if there's something with their email, we cannot review this stuff, which is why we have specific email addresses. So any of us who is assigned to those emails can pull your application if someone is out unexpectedly. Okay, real quick. We actually today welcomed our new plan reviewer, Troy Owens. He is here with us today. And so please allow us some time to get him onboarded. We are very thrilled to have him as a part of our team. And so you will be getting, once he's onboarded and assigned plans, you will see we have new family members here at CMRO. So we're really excited to have folks available to us, new staff in at the regional office. Next slide, please. Okay, urgent plans. We are getting an influx of requests for urgent PCPs. Please understand that I am the person responding to every request for an urgent PCP. Also understand that while your situation may feel urgent for you, it is not necessarily classified as urgent for the regional office. For us, urgency includes health and safety concerns, what the request is, and when the anticipated date is. We continue to get plans that are tagged as urgent without following the appropriate process. And we are continuing to get plans that we have asked to ensure that we have the full 20-day. Here's the deal, folks. If y'all send us plans and every plan is urgent, then it impacts my team's ability to get plans reviewed on time. We, as you guys heard, we have a lot of plans in this office, and it is necessary for me to manage the workflow of my team in order for us to meet deliverables. I promise you that I do review all of the requests, and when we are able to consider that this is an urgent situation for the person, we will move on it. Again, your timing for you might be urgent, but I also have to manage the process in-house, and we need to ensure that we are reviewing things with a clear lens. Also, just because you requested that a plan is urgent does not guarantee approval. We continue to get plans that do not have the information that we need in order to meet waiver requirements. Please ensure that the reason that you indicated that this plan was urgent is properly identified in the plan. If the information for the urgency is not what was requested, not what was explained, and that plan does not require me to approve the plan because it is not in waiver alignment, we will not be able to approve the plan. So please ensure that the plan is in alignment with waiver requirements. Please ensure that when you request a plan to be urgent, that you provide the coordinators with all of the information in the plan. Please do not follow up with the long emails about what was missed. We need that information in the plan. When it is not in the plan, it delays our ability to quickly review a PCP urgently. For the record, I review most of the urgent plans. And if the information is not in the plan based on what you've told me, then I have to send it back in a clarification. Please help us to get a big picture of what is going on so we're able to decision the plan properly. If the plan is ready, I have sat with the CCSs and gone through the plans so that we can make sure that it is done where I have the ability to do so. I do, again, review most of the plans. I will review most of the plans so that we are able to knock out the stuff. Okay. Next slide, please. Just a reminder, incident reports have to be submitted within 24 hours of an incident. Please make sure that if there's, based on the nature of the incident, if you have to notify the agency, the regional office, please do so. You can send it to us via email with the details, and or you may be able to reach out to myself, Shireen, or Travis in order to let us know that there's a concern. Please let us know within 24 hours that there has been an incident. Depending on the nature of the incident, please do not depend on just the incident report. We review quite a few of those daily, and if instant support is needed, please call us. We will call you back. Hospital and or facility discharge needs to be coordinated with the agency nurse included. We have a lot of folks that are in the hospital, or they were sent to rehab because they had a situation that required them to be in a facility, and people are getting back home or people are being discharged, and we have situations where they are not in the right service model, or people are coming back into community with service needs that are not able to be provided within DDA. Please include your nurse as part of the process. Please understand, if your nurse is not able to delegate, then that person can come back with the agency. If the person has gone to a long-term care facility and are there for more than 30 days, then we have to restart the waiver process. So please pull us into the conversations if you are unsure of how we're able to provide support to you. This past week, communication from DDA came out regarding provider roles and responsibilities in the person setting planning process. If you have been a recipient of any the constant contacts from DDA that was sent out, if you need the information, we can try to get that back to you. But it does include information that will help us be able to decision plans. And so it helps in making sure that everyone understands what it is that we need. Next slide, please. Matt, let me, so what you're describing is not the example. So we have indicated that if someone needs ongoing job support because they now have a job, that will be something that I will review, and we will move immediately if we're only adding one service. So yes, no, those are some of the ones that we will do very quickly in order to ensure that someone is able to move quickly for those situations. If we don't have any other updates to the plan, or there's nothing else that would allow for us to ask for a clarification, we'll go ahead and get those done fairly quickly. So especially for those on the job supports, just let us know. A behavior plan should not be developed before someone, there are rare cases when a behavior plan would be developed before a person enters services, because we're not requiring that, because we would not be paying for it without someone being in service. So not sure about that question. For folks that require a behavior plan before they enter service, that's our forensic folks, and we have a mechanism by which that is done. It's not, I can't post the link, Holly. It came out as a constant contact. Can we switch to the next slide, please, so we can wrap up? We are at 12:01. Okay. Well, no, a behavior plan is not necessary for an initial plan for someone to have one-to-one. We need data in order to see whether or not that person has the need for that service. We're also able to temporarily approve one-to-one while the team collects data, but we need information. And sometimes we don't get the information properly in a way that allows for us to understand what the support needs are. You can send that to me. There would be a reason why we probably didn't get the information that we need. Go ahead and send me that LTSS ID number. The information is specific to each person. I can't give you a list. Work with your CCS. They work with your CCSs. We need to understand why someone needs this level of support so that we're able to provide support to you. This is the end of our meeting. Happy April and happy spring. We will be back at this again in July. And in the meantime, please remember that your regional office staff is here to provide support to you and your staff. So please reach out to us in order to get all of your concerns addressed. Please give us a little bit of grace because we're getting a lot of emails and it's taking us quite a bit longer than normal to respond. And we will continue to do our best to get the responses to you as quickly as we are able to. If there was something that I mentioned today that you need additional information about, please reach out via email. And if it's a longer conversation, we can schedule a call. In the meantime, have a beautiful, beautiful week. That information, Mr. Felix, is in the waiver regarding what is how behavior supports are billed. It's in the waiver and it's in the billing guide. Okay. Have a good rest of your day, everyone, and we will see you again in July. Allison?